The various ways of measuring adherence are not always accurate, and each one provides a separate set of problems. Ask a clinician. This is not very reliable. It will generally overestimate their patient's adherence. Ask the patient. Evidence shows that these reports are accurate, but most studies indicate that this is not a good way to measure noncompliance. There are two problems here: social desirability, and patients may not know their own rate of compliance. They may underreport poor adherence, but also overreport good adherence. Ask other people, hospital personnel or family. The problems with this method is that constant observation may not be possible, and persistent monitoring creates an artificial situation. Count pills. The problems. Even if required number of pills are gone, the patient could have thrown some away or may have taken them in a manner other than the prescribed one. Examine the biochemical evidence. For example, the analysis of blood or urine samples. This is more reliable than pill counts, but also more expensive. Problems. Some drugs are not easily detected in blood or urine. Also, individual differences in absorption and metabolism can lead to wide variations in people who are equally compliant. Checks must be carried out frequently and regularly. Otherwise, we don't know if a person has been taking medication regularly or did so just before the appointment. What factors predict adherence? Aspects of the regimen. If there are unpleasant side effects of a medication, or if it is too complex, adherence will probably be low. Adherence decreases as length of treatment increases. For example, if medication is prescribed over a long time, it is more likely to be discontinued early. The greater the effort required for adherence, or the greater the lifestyle change necessitated, the lower adherence is likely to be. Personal characteristics. Age. Depending on the specific illness, time frame, and adherence regimen, studies show adherence either increases or decreases with age. Adherence to treatment regimens for heart disease, hypertension, and diabetes tends to increase as people get older. For colorectal screening, 70-year-olds were most compliant. Those younger than 55 or older than 80 were least compliant. Socio-demographic factors, age, gender, ethnicity, personality, do not predict adherence to diabetes regimens. Gender. There are a few differences between overall adherence rates of women and men, but some difficulties in specific recommendations. Several studies found they were equal in the tendency to stay or drop out of exercise programs, but women were better at adhering to healthy diets and taking some types of medication. Selwood and Terrier in 1994 found that men were more resistant to taking medication for a mental disorder. Social support. The meta-analysis by DiMatteo in 2004 showed that practical support, instrumental assistance, reminders, support for specific behaviors, was the strongest predictor of adherence. Emotional support also predictive, but not as strong. Adherence was 1.74 times higher in patients from cohesive families and 1.53 times lower in families with high conflict. Marital status and living with another person for adults increases adherence modestly. Sherwood in 1983 found that the highest adherence among hemodialysis patients occurred when families were neither emotionally distant nor emotionally over-involved. Living with another person who is part of the same adherence procedure increases the individual's adherence. Thomas in 1995 found that people who lived with another participant in the study were more likely to comply with a cancer screening regimen than those who lived in a household where they were the only participant. Sherborne in 1992 found the number of friends of a diabetic patient had was unrelated to a patient's compliance, but quality of interpersonal relationships was a significant predictor of adherence. But there was no relation between social support and adherence for patients with hypertension or heart disease. Other research has found that support of family and friends relates to adherence in heart patients. The differences are likely explained by different ways of measuring social support in the research. Kulik and Mailer in 1993 investigated men who had bypass surgery. Married men were more likely to have complied with a doctor's advice to smoke less and walk more. However, when equated for emotional support, married and unmarried showed no difference in levels of compliance. Personality traits. Situational variables are much better predictors of adherence than our stable personality traits. Most early studies that found correlations did not use standardized personality inventories. Research in 1988 found that only scores on obsessive-compulsive scale predicted adherence to a stress reduction program. Physicians are inept at predicting which patients are most likely to be non-compliant. Lutz in 1983 exposed a group of people experiencing intense pain to 5 different pain relief regimens and found compliance with one program was unrelated to compliance with others. Research with diabetic patients found similar results. However, being in a good mood and having optimistic expectations are important. Being depressed reduces adherence. Religious beliefs. Religion and spirituality factors are related to compliance with treatment among those with existing health problems. A prospective study of community-dwelling older adults found a protective effect of religious activity on subsequent high blood pressure. In those who had been told that they had high blood pressure, their extent of religious activity was positively related to taking their blood pressure medication. Personal beliefs. When patients believe that adherence to treatment recommendations will result in health benefits, they're likely to comply with those recommendations. Brownlee and Dufek in 1987 examined health beliefs and their effects on adherence to diabetic treatment regimens. For adults, the belief that compliance will benefit one's health predicted adherence. For adolescents, perceived health benefits of compliance were not important. They were more likely to comply when they were experiencing immediate discomfort. Sherborne in 1992 found that the best predictor of non-adherence to medical advice for hypertension, diabetes, and heart disease 2 years later was non-adherence at the beginning of the study. The next strongest predictor was avoidance coping. This means that they may have denied the efficacy of advice or rejected responsibility of their own health care. Cultural norms. Zaya Zima in 1984 interviewed people in Zimbabwe who were suffering from hypertension and diabetes and who were not adhering to recommended therapies. Many still believed in traditional healers and had little faith in modern medical procedures. Ruiz and Ruiz in 1983 found that Latino patients were more likely to comply with medical advice when their physicians demonstrated some understanding of Hispanic cultural norms and practices. The patient-practitioner interaction. Poor patient-practitioner communication and non-adherence. Non-adherence refers to patients not adopting the behaviors and treatments their practitioners recommend. The estimates of non-adherence vary from 15% to 93%. Causes of non-adherence. Whether or not the patient has made the decision to adhere. The following promote higher levels of adherence: belief in vulnerability to disorder, belief that disorder is serious, belief in efficacy and recommended treatment, belief that one will be able to carry out the plan. Whether or not the patient understands the treatment regimen. The following promote high levels of adherence: the patient is asked to repeat instructions. Instructions are written down. If unclear, recommendations are pointed out and clarified. If instructions are repeated more than once. Whether or not the patient is satisfied with their relationship with the practitioner. When patients perceive practitioners to be warm and caring, they are more adherent, and vice versa. The following practitioners have more adherent patients: those who answer questions and give information regarding symptoms, those with busier practices, those who schedule follow-up appointments, those who order tests. What the qualities of the treatment are. The following yield low levels of adherence: regimens that must be followed over a long time, regimens that are complex, regimens that interfere with other desirable behaviors in a person's life. Adherence is high, 90%, when advice is perceived as medical. Adherence is lower, 76%, if it involves vocation. For example, you must take time off of work. Adherence is even lower, 66%, if the advice is social or psychological. For example, avoid stress. Adherence is very poor, 20 to 50%, when the patient is asked to change their habits. Demographics in adherence and non-adherence. Women, whites, and older people are more likely to follow prescriptions. Patients with a variety of chronic disorders who relied on avoidant coping strategies were less likely to follow their doctor's specific recommendations and to adhere to treatment goals in general. Creative non-compliance. In other words, intelligent non-adherence. This involves modifying and supplementing a prescribed treatment regimen. An example would be that a poor patient may take less to stretch out medications or save some for another family member. Creative non-compliance can result from private theories about a disorder and its treatment. An example of this would be when a patient may alter dosage requirements, reasoning that if 4 pills a day for 10 days will cure, then 8 pills for 5 days will do it twice as quickly. This may be a way to reassert control over the patient-practitioner relationship and the illness. Reese, in 1993, found that patients with asthma use their sprays for relief more often than prescribed. Reactance. This is a psychological state resulting when people feel their freedom has been threatened. The person may be especially sensitive to self-label as a sick person. An example would be a man at risk of a heart attack. Each time he declines a cigar, he reminds himself that he is sick, which may be intolerable to him.